Hello everyone, this is Jungheum and I would like to thank KJR for giving me such an honorable opportunity to present this research on behalf of other authors. I would like to talk about appendiceal visualization on 2 millisievert CT versus conventional dose CT in patients with suspected appendicitis. This study is an analysis of large pragmatic randomized trial data. CT is the mainstay of diagnostic tests in adults with suspected appendicitis. Previous studies showed lowering CT radiation dose down to 2 millisievert for diagnosing appendicitis, as it hardly hinders clinical outcomes or diagnostic performance. Other previous studies showed conventional radiation doses have advocated using appendiceal non-visualization of CT as a reliable sign to exclude appendicitis with a negative predictive value of over 95%. However, some practitioners are concerned that appendiceal non-visualization is more common with the use of low-dose CT instead of conventional dose CT, which may lead to undesirable clinical or diagnostic outcomes such as negative appendectomy, perforated appendicitis, or delay in patient's management. So the purpose of this study was to compare appendiceal visualization on 2 millisievert CT versus conventional dose CT in patients with suspected appendicitis and analyzed undesirable clinical and diagnostic outcomes that followed appendiceal non-visualization. Here we report a previous unreported part of the research and postdoc analysis of previous pragmatic randomized controlled trials, so-called LOCAT, which compared 2 millisievert CT and CT in patients with suspected appendicitis. The main trial report addressed the non-inferiority of 2 millisievert CT compared to CT with respect to negative appendectomy rate and appendiceal perforation rate. We randomized about 3,000 patients to undergo contrast against 2 millisievert CT or CT from December 2013 through August 2016 in 20 hospitals. 161 radiologists prospectively rated appendiceal visualization using a 3-point Likert scale and likelihood of appendicitis using 5-point Likert scale. Final diagnosis was based on CT image, surgical pathologic, and clinical findings. We used the standardized referred form for suspected appendicitis and regraded the visualization of the appendix in 3-point Likert scale. Grade 0 means not identified, grade 1 unsure or partly visualized, and grade 2 clearly and entirely visualized. We compared the 2 millisievert CT and CT groups for appendiceal visualization and negative predictive value of appendiceal non-visualization for ruling out appendicitis in each group. We defined appendiceal non-visualization as appendiceal visualization grade 1 or 0. As post-analysis, we analyzed undesirable clinical and diagnostic outcomes following appendiceal non-visualization. We particularly interested in negative appendectomy and perforated appendicitis, as well as false positive and false negative diagnosis. We did sensitivity analysis by defining appendiceal non-visualization as only visualization grade 0. Here are results. These are patient diagram. The number of patients with appendiceal non-visualization was slightly more frequent in 2 millisievert CT group than in the CT group. Negative predictive value of appendiceal non-visualization for ruling out appendicitis were 78% and 79% in the two groups respectively. Here are some representative images of appendiceal visualization. This picture shows grade 2 clearly and entirely visualized appendix. grade 1 unsure or partially visualized appendix, and grade 0, the appendix is not identified. In terms of finer diagnosis, perforated appendicitis was rare in both groups, but tended to be more frequent in the 2 millisievert CT group than in the CT group, showing minor difference. Negative appendectomy was also rare and comparable between the two groups. In terms of patient disposition, undesirable outcomes were rare in both groups. The 2 millisievert CT group and CT groups did not differ significantly in the need for extensive surgery to treat appendicitis, surgeries other than appendectomy, additional imaging tests, interval between CT and appendectomy, length of hospital stay with appendectomy, interval between CT and discharge without surgery. The majority of patients with appendiceal non-visualization on CT still had true positive or true negative results for the presence of appendicitis. False negative and false positive diagnoses were rare in both groups. False negative diagnoses were noted only in the 2 millisievert CT group, and false positive diagnoses were comparable between the two groups. There were 6 and 5 adverse events following appendiceal non-visualization in the two groups respectively, and all the events were resolved without sequelae. In the sensitivity analysis, by defining appendiceal non-visualization as only visualization group grade 0, the results were largely consistent with those of the primary analysis. Appendiceal non-visualization occurred in 15 and 6% of patients in the 2 millisievert CT and conventional CT groups, respectively. In both groups, the majority of patients with appendiceal non-visualization on CT still had true positive or true negative results for the presence of appendicitis, and undesirable events were rare. Perforated appendicitis and false negative diagnosis following appendiceal non-visualization were slightly more frequent in the 2 millisievert CT group than in the CT group. However, the differences were minute. The two groups were comparable for the negative appendectomy and false positive diagnosis, as well as for other undesirable outcomes following appendiceal non-visualization. Our results have important implications for managing patients with appendiceal non-visualization, which is a challenging situation in practice. First, although the appendix is well visualized in more than 85% of patients, even on 2 millisievert CT, appendiceal visualization is slightly hampered with the use of 2 millisievert CT instead of CT. Second, appendiceal non-visualization rarely leads to undesirable outcomes even with the use of 2 millisievert CT instead of CT. Our research however provides further evidence justifying the use of 2 millisievert CT instead of CT, and it is particularly interesting that the radiologists could still correctly diagnose or rule out appendicitis in most cases with appendiceal non-visualization. We assumed that radiologists could rely on secondary findings such as fat infiltration or fluid collection in the right low quadrant abdomen. Third, nevertheless, more caution should be made in clinical decision-making following appendiceal visualization on 2 millisievert CT, particularly to avoid the risk of false negative diagnosis and subsequent appendiceal perforation. Some cases in our study with initially negative CT results and appendiceal non-visualization may benefit from second reading by more experienced radiologists or from additional imaging tests for more accurate diagnosis and appropriate patient disposition. Fourth, from our results showing negative predictive value below 80% in both groups, we conclude that appendiceal non-visualization cannot serve solely as a sign for ruling out appendicitis not only on 2 millisievert CT but also on CT. The disparity from the previous retrospective studies that reported negative predictive value over 95% may be partly attributed to inconsistent definition of appendiceal non-visualization, which is intrinsically a matter of radiologist's subjective decision. In conclusion, the use of 2 millisievert CT instead of conventional dose CT impairs appendiceal visualization in more patients. However, appendiceal non-visualization on 2 millisievert CT rarely leads to undesirable clinical or diagnostic outcomes. Nevertheless, we encourage second reading by more experienced radiologists or additional imaging tests where the appendix is not visualized at 2 millisievert CT to prevent increase in potential false negative diagnosis or appendiceal perforation. Thank you for your attention.